Hey everyone, welcome back to Heart Health with Michelle. Today I have a really exciting guest, Dr. Seth Martin. He is a cardiologist at John Hopkins, and he's the director of Lipid disorder. Today we're going to talk about genetics and the difference between having a family history of heart disease and having a genetic lipoprotein metabolism disorder, how we differentiate that, and really, how do we address it if we have that? So I want to first take a few minutes to have Dr. Martin introduce himself, and then we'll get right into our time together.
Great. Thank you. It's exciting to be a guest on your program and have this conversation. I hope it turns out to be very useful to your listeners. It's especially exciting to be here during Heart Month, where really throughout the month of February, we're trying to raise awareness around heart health. And I have a particular passion for speaking around the role of genetics and cholesterol in my role as director of the Lipid clinic, where I take care of patients and families with familial hypercholesterolemia.
Yeah, I'm so glad that you're here. So, I have every time a client calls me to decide if they want to work with me for nutrition counseling or heart disease and heart disease management, I always screen them and make sure that I can help them. But I ask a lot of questions to see, what's going on with what they have and see how I can best guide them as well. And oftentimes people say, I have really high cholesterol. I've had it for a while and I don't know, I want to work on diet first before I go on medicine. And so the first question I usually ask, well, what was the LDL, the lowest LDL you've had? What does your lipid panel look like? And a lot of times people tell me their LDL is 300 or their LDL is 275. And I take a step back and I say, did you see a lipidologist? Were you diagnosed with familial hypercholesterolemia? And a lot of times they're like, what's that? No one's ever told me that. They just told me to monitor it and to diet and exercise. And I say, no, we need to dive deeper into this because it's so important that we address this appropriately. So I'd love for you to kind of explain to the audience, what is the difference between familial hypercholesterolemia and let's just say high cholesterol because it may run in my family?
Right. Thank you. Thank you so much for asking this. So the familial hypercholesterolemia is a very specific condition where one is born with a gene inherited from either mom or dad. There's a 50% chance of passing it on if a parent has it. And that's where the cholesterol is very high, can be 300 from birth. And that is a condition that we want to diagnose and treat early. So familial hypercholesterolemia, although I think often we think of a genetic condition as a rare condition, most of us don't need to worry about it. This is a condition that affects over 1 million people in our country, more than 10 million people around the world. So that it's out there, and and I think we should think about the LDL levels, put them in context. So a level of 300 is very high. Our American Heart Association guidance says that a level of 190 milligrams per deciliter or more is considered to be severely elevated. So 300 is very high. Once we start getting above that level of 190, we should be thinking really seriously about the possibility of an inherited condition, particularly familial hypercholesterolemia. Now, if somebody, you asked me to kind of contrast things, if somebody has a more typical LDL level that it's a little bit high, the average American has LDL levels around 115, 120. So if somebody's level is, let's say 130, 140, it's a little bit high, and certainly diet, lifestyle habits may be playing a role, as well as genes playing a role, but not that one specific gene that has that big effect driving up LDL. It could be a combination of genes combined with environment that's leading to a more mild elevation in LDL cholesterol levels. And there could be a family history of heart disease in either case, but that magnitude of the LDL level, when it's more severe, particularly in a family that has early heart disease, really is a red flag for familial hypercholesterolemia, the family history plus the LDL. And that family history can look like people having bypass surgery in their 30s or 40s, heart attacks in their 30s or 40s, early in life, and it kind of running through particularly one side of a family, because it's again being passed down from parent to child, parent to child. So I'm glad you brought this up, and I really would love to kind of speak more around how we kind of other physical exam features and really how we all the advancements we've had in terms of treatment approaches for familial hypercholesterolemia, as well as strong support from patient-run organizations like the Family Heart Foundation.
Yeah, I'd love to dive into that more. I'm curious to understand kind of, you mentioned the diagnostic features that we need for familial hypercholesterolemia. But can you go into a little bit more detail about what's happening in the body that's causing the LDL at such a high level?
Right. So this is really kind of happening at the liver, where we have in our body, in order to clear LDL cholesterol. By the way, LDL cholesterol, we can consider this to kind of be the garbage of our body's lipid metabolism. So even if you have zero LDL, you still have cholesterol in your body. Your cholesterol is serving functions in the body, but LDL is kind of the leftover garbage that the body wants to clear out. And it clears it out in the liver by basically grabbing the LDLs with this LDL receptor. They're like the garbage trucks that are clearing out the LDLs. And so you want more of those garbage trucks. And in some of your other discussions, you may have spoken around apolipoprotein B, which is the particular protein that wraps around these LDL particles. It's kind of like the stitching of a baseball on the baseball that it wraps around the lipoprotein. So what can cause familial hypercholesterolemia can be some defect in the way that LDL particle with the ApoB binds to the LDL receptor. So there could be, first of all, the LDL receptors themselves, there could be a genetic mutation that leads them to not work as well, or there's not enough of them, or there's a problem, a mutation in ApoB, so that the receptors don't bind to the LDL, to ApoB and the LDL particles well. Or there can be a defect in something called PCSK9, an enzyme which is related to the breakdown of the LDL receptors. The most common mutation is a mutation directly in that LDL receptor. Again, I like to call them the garbage trucks in the liver. And that's really the inherited factor that leads somebody's cholesterol levels to be high from birth if they've inherited FH. We call this shorthand for familial hypercholesterolemia that we use in the kind of the medical community and within the world of familial hypercholesterolemia is we call it FH for shorthand.
Yeah, no, that's definitely helpful. So whenever we talk about lowering your LDL, improving your risk profile for cardiovascular disease, we talk about the importance of nutrition and lifestyle. And I think it's really important to emphasize that always matters, whether you have a genetic metabolism disorder or you have family history or just generally speaking. But I really focus on the importance of why it's important that can't be the only treatment if you have FH.
Right. So if you have FH, the nutrition definitely is important, but it's not enough because you have this, again, problem clearing out the LDLs, the ApoB containing particles. And so because you can't clear them out as well, there really needs to be a pharmaceutical intervention to basically improve that clearance system. And that's where we have statin medications, but now we have multiple non-statin medicines, ezetimibe, Zetia, PCSK9 inhibitors like evolocumab or Repatha or alirocumab, known as Praluent. There's now bempedoic acid, also known as Nexletol, and there's even a new medicine for patients with homozygous familial hypercholesterolemia, where one has inherited it from both parents, and that medicine's called evenacumab, or Evkeeza is the brand name. So the point is, we have actually a whole lot of pharmaceutical agents that have been really shown clearly in clinical trials to be efficacious. They work and they're safe. And typically someone with familial hypercholesterolemia needs a combination approach of healthy diet and lifestyle plus statin and non-statin medications to get that LDL down low. I guess something to mention, we talked about what sort of an LDL of 190 is considered severely high. These days, we're often aiming for LDL levels at least below 100, typically less than 70, or even in very high-risk populations, less than 55. So if you're starting at 300 to get down below 55, that's a long way to go. And so that really is why we need to take a combination treatment approach.
Definitely. I think a lot of times what I see is many people are unaware of what to do. So I see a lot of clients who have these high numbers and they've just seen a general cardiologist who says, you know what, you're thin, you don't have any other risk factors, let's just monitor it. What's the danger of keeping that LDL so high?
Really the risk of developing heart attacks, strokes is a key danger, and it's related to that cumulative kind of exposure. I mean, it's one thing to have a high LDL for a year or two, but if you were born with it as a kid, now even at a young age, you've been exposed to multiple decades of high LDL. So your arteries have already been exposed to that risk in developing plaque early in life. And so if that is left kind of unabated, it's really that cumulative exposure. The years that you're exposed to high LDL levels is just rapidly accumulating. And so that's why we see someone in their 30s developing a heart attack or needing bypass surgery, whereas typically we don't think of that as happening to someone until they're in their 60s or 70s or 80s. So it's just the whole process of plaque buildup in the arteries is accelerated. And so that's why early intervention is critically important. Now, if you wait, 3 months, 6 months, for most people, that's probably not going to be a key difference. But ultimately, getting on treatment earlier in life and then staying on it over the long term to reduce that cumulative exposure will be really critical. So it's certain, for familial hypercholesterolemia, it's different again than the general population, where maybe trying 3 to 6 months of lifestyle changes could be perfectly reasonable. But I think in this case, if you're starting with such a high baseline LDL, I think starting to explore getting connected with a specialist, in addition to working on nutrition-based approaches, can be important. And the FH Foundation on their website does have care navigation services and a list of specialists that can help. And they have information for all over the U.S.
Yeah, I think that's really important. I mean, from my perspective, most of my clients, when they're just looking at diet alone, we can bring down LDL 40, 60 points in about 3 to 4 months. It's pretty remarkable.
Yeah.
But if you're starting at 300, you're not getting down to less than 100 or less than 70 in those 3 to 6 months. Especially when FH, it's a genetic metabolism disorder. It's not going to reduce that. It's not going to have that effect without that therapeutic, medication. I think you also mentioned an important point of, honoring your lipids, and you're seeing that your lipids are very high. It's important that you look for a lipidologist who specializes in lipid disorders. A general cardiologist might not have as much knowledge as obviously someone like you, who has all of this understanding of the different combinations, the different therapies, and what can work to really make sure that we're reducing your risk of cardiovascular disease and preventing early heart disease and early complications. One of the things that I want to ask and mention is, there's a lot of different genetic components to heart disease, and familial hypercholesterolemia is one. But what about things like lipoprotein A? What's your take on people getting tested for that, and how might it correlate with familial hypercholesterolemia?
Yeah, thank you. We do test routinely for lipoprotein A in our clinic, in our lipid clinic, and it is an emerging risk factor and possible treatment target. So it is an inherited condition. The levels of lipoprotein A are predominantly genetically determined, but we typically assess it through just a simple blood test. Because the levels are so genetically determined, we really rely on that blood test to see if someone has high LPA and if that's running through the family. If there's labs measured in different ways, and that's still being improved and standardized. The recommended way is to measure it in nanomoles per liter, which is the concentration of the LPA particles. LPA is a low density lipoprotein-like particle that has this ApoA attached to it that seems to make it particularly pro-atherogenic, basically promoting atherosclerosis formation in the arteries. And it seems to be quite common at the current levels that we consider to be high of over 100 or over 125 nanomoles per liter. We're talking about a fifth of the population, 20% of people that have high levels. And certainly if you're a patient with familial hypercholesterolemia, there's no exclusion. You can have both at the same time, but most of the people that have high LPA will have it without familial hypercholesterolemia. But this can be another important risk factor and a factor that runs through families, and currently directed therapies are in testing in clinical trials. And so if those pan out, there could be a directed treatment approach. At the moment, the treatment approach is to lower other traditional risk factors: cholesterol, blood pressure, optimize nutrition, lifestyle, avoid smoking, and so forth. But the FH Foundation, they used to be called the Familial Hypercholesterolemia Foundation. Now the Family Heart Foundation, they have great information on their website around lipoprotein A as well.
Yeah, no, that's great. Whenever someone comes to me with a lipoprotein that's elevated, their cholesterol levels are actually most of the time not very high.
Yeah.
But it's an important risk factor to say, okay, I have this genetic component that puts me at increased risk of not just atherosclerosis, but now we're seeing heart failure is increased. It's more connected with blood clotting disorders and a lot of other issues. So our biggest thing is, how proactive can we be? So our LDL guidelines are stricter, are looking at your blood pressure, your blood sugar levels, your waist circumference, your smoking, your lifestyle, your stress, your sleep, all of it matters.
Right.
And so I always say, everyone should get it tested once, because it's not really going to change right now. We don't have that targeted treatment, but we should know about it so that we can be more proactive in our approach.
That's exactly right. Yeah, I totally agree.
I think a concern that I see a lot in my practice too, just going back to FH, is that some women are trying to get pregnant or they're around pregnant age. And so, they're saying my cholesterol is high and I have FH, but I want to have kids, and kind of how do we weigh that? I also see men who are concerned that it will affect their offspring and that aspect of it as well. So if you could touch upon that, I think that would help answer or relieve some concerns that many people have.
Sure. Yeah. I mean, I think this is where your point around, having a lipid specialist that you're working with is really important, to kind of engage in the shared decision-making and have this kind of back and forth about your particular situation, and to consider having formal genetic testing. Although familial hypercholesterolemia can be diagnosed on clinical grounds based on somebody's LDL levels and family history, plus minus other factors like physical exam findings like xanthomas and corneal arcus. Although a clinical diagnosis can be made, increasingly we use genetic testing to actually have a genetic diagnosis, and then you can have even greater clarity around family planning, around whether there is a specific pathogenic mutation that could be passed on. So I think that's worth considering. And then when it comes to pregnancy, this is where there a couple kind of things I would say, is that number one, if a woman had gotten diagnosed early in life and treated for familial hypercholesterolemia really well, kind of, dating back to childhood. Like, by the way, like the recommendation would be to start treatment often around age 8, if not earlier, if someone gets diagnosed earlier. So if someone had been diagnosed well and treated early in life, I would be much less worried around pregnancy, because you're kind of going off of treatment for a relatively short duration in the window of time in someone's life. However, if someone has not is getting diagnosed at the time of pregnancy, that's a bit of a different situation. And I think there may be, be a little more nuanced discussions around sort of if there should be any atherosclerosis imaging to sort of see if plaque is present and to kind of have a better sense of what the risk may be around the time of pregnancy. Generally, we do avoid lipid medications during pregnancy. However, there has been some changes in recommendations. For example, the FDA put out a statement that statin medications can be considered for FH patients during pregnancy. So this again gets back to kind of the need to have that careful kind of dialogue with a specialist and to kind of engage in shared decision making and come up with a plan that really best suits you.
Definitely.
Yeah.
That's really helpful. Yeah, this has been great. I think that this is really informative and really hopefully the audience understands the importance of seeking further information, seeking a specialist to really tailor care.
Yeah.
Combining, diet and nutrition is going to matter in all cardiovascular diseases, but sometimes we need medication because it's needed. And so we need to understand why in that component to really create a plan that's going to work for you and truly reduce your risk of heart attacks and strokes. Any thoughts, any last minute comments you'd like to share with everyone before we sign up?
I'd like to just reinforce what you said. It's so important to kind of take it seriously. And it's not about like a competition between nutrition and medicines. It's complementary approaches that are needed, and genetics kind of change the circumstances in a way that even with the best nutrition, those genes can't be totally counteracted. And you may need, and we're very fortunate to have decades of advancements and therapies available that work really well and that are really safe. So I just highly encourage folks to kind of take it seriously and work with a specialist. And it's about if you find that you have really high LDL levels, it's about you personally, but it's also about the family and a chance to really take the best care of children and all future generations of a family.
Definitely. And also know that, if statins, or if you are intolerant to statins or that doesn't work for you, there's so many other options, and it needs to be discussed for to make sure that you find the right treatment that works for you and that you feel good on, and it improves your quality of life, because you shouldn't be on anything where you feel lethargic, uncomfortable. We want to make sure that this is a collaborative approach that works. And so that open communication is essential for your dietitian, your medical doctor, your nurse, everybody in it together, so we can truly help you. Thank you so much for being on here. Where can people follow you in terms of social media, or where can people kind of look you up? Where can I send them?
Thank you so much. I in terms of social media, I am on Twitter at Seth Shay Martin. I'm, not a super user of Twitter, but I'm on there and do my best. So you can follow me there. And certainly if you're someone who lives in kind of the Baltimore, DC area, and you or your family members are concerned around their lipids and would like to come in and see a specialist, I direct our clinic. We have 6 different physicians as well as a full multidisciplinary team in our clinic. So would certainly welcome you to reach out to our Johns Hopkins team, and you can find us on the Johns Hopkins website through our Lipid Clinic website.
Wonderful. Thank you so much. It was a pleasure having you. I appreciate your time.
Thank you so much.